Hello to everyone and welcome to this M8 Alliance webinar on how climate change affects the health of migrants and refugees. My name is Luciano Saso and I'm a vice rector at the Sapienza University of Rome and member of the executive committee of the M8 Alliance. Migrant and refugee health has been an important topic for the World Health Summit since 2016, and many sessions were organized at the annual event in Berlin, at regional meetings, and at more specific expert meetings. In this difficult and tragic COVID period, we organize monthly webinars. More information and the link for free registration at the next webinars is available at the World Health Summit page dedicated to migrant and refugee health. For this meeting today, I would like to thank very much François Germain from the Hugo Observatory Department of Geography, University of Liège in Belgium, and all distinguished speakers who accepted our invitation. I would like to thank very much the World Health Summit team in Berlin, and especially Nora Anton, Alea Goodman, Alida Tiekotter, and Frederic Sontag. I would like to thank very much all participants for being online with us today, and I wish everyone a very pleasant and fruitful meeting. Thank you again, and François, please, you have the screen.
Thank you, Luciano, and my warmest thanks for organizing this webinar today. Many thanks also to the M8 Alliance and for taking into account this important topic of the connections between climate change, health, and migrants. And today we shall hear from very different perspectives, both from academia and policymaking and practitioners, to look at basically how climate change is affecting the health of migrants. We know, of course, that climate change will induce migration flows and is already inducing migration flows. We also know that climate change has differentiated effects on public health, but we will try and bring these three dimensions together in this webinar of today. So I will give each speaker about 10 minutes to present their views and their key points. And then after all speakers have made their point, I will invite the public in the audience for a discussion. I want to point out that while the speakers are speaking, you are free to address your questions in the chat box of this webinar, and we will also address the questions that have been asked in the chat box over the course of the presentations. But without further ado, I would like to introduce our first speaker, Miriam Orkut. Miriam, you work for the Lancet Migration. So we all know the Lancet as a medical journal. We know that a few years ago, the Lancet has launched an initiative on climate change to document the health impacts of climate change. It is called the Lancet Countdown Initiative. And more recently, you have also launched a new initiative on migration, the Lancet Migration. So if you could introduce us to this initiative and to the interactions between migration, climate change, and health, and possibly also how you conceive the interaction between the Lancet Countdown Initiative and the Lancet Migration. So thanks for being with us, Miriam. The floor is yours until for about 10 minutes.
Thank you so much, and very much thanks to the organizers of this event. It's a real pleasure to be here. And as mentioned, today I'm representing Lancet Migration, and we focus on the intersection between migration and health, but one of our priority areas is actually climate change, migration, and health. And I'd like to thank some of my colleagues at Lancet Migration, particularly our research fellow on climate change, migration, health, for their inputs into this presentation. So I'm going to briefly focus on or highlight some of the existing evidence across the fields of migration, climate change, and health before identifying a few of the research gaps and priorities within the nexus of these three complex systems. And I will briefly mention Lancet Migration and some of the work that we focus on. And finally, I'll just move on to talk a little bit about some suggestions for moving forward within this field. So in terms of just briefly some background, as we move through the 21st century, we know that both acute and chronic impacts of climate change will influence both push and pull factors for migration. There are estimates about movement of environmental migrants, which range between 25 million and 1 billion, who will move both within borders as well as across borders by 2050. And there's also projections within regions, for example, Sub-Saharan Africa, South Asia and Latin America alone are projected to see over 140 million people moving within their countries' borders by 2050. That's an estimate from the World Bank. And we know that many of these individuals will be exposed to heightened health risks or have greater healthcare requirements due to either direct or indirect impacts of climate change. And many of those who are most vulnerable to these impacts will be individuals who have also less capacity to cope, including those living in poverty, children, women, those who are disabled, the elderly, landless, marginalized, and people who are often living already within challenging circumstances. We know that, the health consequences of climate change are very well recognized. As mentioned at the beginning, Lancet Countdown is also an initiative of the Lancet, and this is a diagram from them demonstrating that climate change will have or has already had and is having an overall significant detrimental health impact at population level and will likely continue to do so. And these health impacts are a result of both direct and indirect causes, likely to affect disproportionately those regions who are who are poorer or also warmer regions. And of course, many of these will be influenced by both resilience as well as adaptation and mitigation measures. Of course, as well, we know that there's also a well-recognized interaction and nexus between migration and health itself. This is from our UCL Lancet Commission on Migration and Health. We know that almost 1 in 7 of the world's population is living in a different location to that in which they were born. We also know that individuals' decisions to migrate are very rarely straightforward, and there's a very big interplay and interaction between a lot of different factors, including social, political, economic, environmental factors. So already there's 2 complex different areas, migration and health and climate change and health. So what does the literature show in terms of the nexus between these? So there have been various attempts to sort of study this interface of these complex interactions, but it has proven challenging to quantify, predict, and project. This research field is relatively a new field in terms of linking these 2 areas. But studies have found that various studies have found either climate-related migration is a last resort, that climate-related migration is a successful adaptation strategy, or they have also characterized it as a failure to adapt to in situ the challenges posed by climate change. So there's been various different perspectives, but there is growing concern about also those populations who are immobile or who are trapped. This diagram represents some of the research which shows the interaction between climate change, migration, and health is complex. It does highlight the interaction between vulnerability, exposure, and the climate change impact. So it's not just one aspect, it's not just climate change impacts, but actually how vulnerable is that population and what is their degree of exposure, which will ultimately impact their mobility decision. And of course, there are different types of mobility as a result of the exposure to environmental change. And that might be relocation, it might be migration, whether within country or across borders. It might be people who are forcibly displaced, and also it may be individuals who are trapped or who are actually immobile. We also know that there are operational frameworks for example, responsive health systems to climate change, talked about as climate resilience health systems. And this is a diagram by the WHO. But where does mobility fit within this? And how do we also include and acknowledge the need for migrant inclusive health systems, which is very much acknowledged both within research, but also within policy in the Global Compacts for Migration and Refugees, as well as the Sustainable Development Goal 3 directly mention not only the need to include migrants within health systems, but to ensure healthy lives and well-being for all individuals. There have been various models proposed in terms of the intersection between mobility, health impacts, and climate change. This is one. And one thing that I think was very key about this particular model is that not only does it define different aspects of mobility, different health impacts, different climate change impacts, but also the fact that in the middle there, you can see that individuals will both migrate away from sites of climate risk, but also there will be mobility into sites of climate risk. And I think we don't always consider that. And in addition, this idea about immobility in sites of climate risk, those who are left behind. So what have we been doing at Lancet Migration? Very briefly, we're a global collaboration between the Lancet researchers and implementers and others in the field of migration health. And we aim to address evidence gaps and drive policy change via research, policy and public engagement and advocacy. And it builds on the recommendations of the UCL Lancet Commission on Migration and Health. We have two main research priority areas, one of which is climate change, migration and health, and the other is universal health coverage and migration. And our objectives overall are to really transform evidence into action, to undertake high quality research, but also to bridge that research policy and practice divide. And we've done quite a lot of work over the last 2 years since we were formed after the Commission, including the establishment of regional hubs, which are established at the moment, the European and Latin American regional hub, through which we develop both research as well as policy and advocacy work. But in the field of climate change, migration and health, what have been some of our guiding principles on this topic? So first of all, I thought these were just some of the key things to highlight that have really informed the way in which we think. Migration is neither inherently a positive or a negative response to climate risk. Planned and proactive migration may be a necessary and effective response to climate change. And actually uncoordinated and distressed migration is very much a sign of adaptation failure. So a sign that we haven't managed to adapt or prepare sufficiently. But also this idea of preparing for immobility as a key aspect of climate change, migration health, which needs to be considered. Of course, one of the things that unfortunately we know very well is that many migrant groups, and we've seen this very clearly during COVID-19, we have some situational briefs on our website which show at country level some of the challenges which migrants and refugees have faced during COVID-19 in terms of access to healthcare, because we know that unfortunately many migrant groups are already excluded from health systems and have challenges in accessing healthcare. So when we're then also considering the added dimension of climate change induced migration, there are significant challenges there. So what have been some of the research challenges that we've identified? Of course, there are huge, as I've mentioned at the beginning, huge complexities in the link between these topics. Very briefly, just some of the limitations that we found. Attempts to quantify both current and future numbers of people who will migrate due to climate change have been challenging. That's because of, first of all, a difficulty in defining and beginning to count, therefore, and quantify climate migrants. Secondly, there's a question of whether migrating is caused directly by climate change, or are there other factors, or is it a failure to adapt in situ? And thirdly, there are issues in data collection, standards. There's often more data around populations who are displaced as a result of extreme weather events rather than slow onset environmental change. And finally, information on people moving has been often limited due to the fact that we do, at the moment, there hasn't been a huge amount of focus in terms of funding and existing large research collaborations on this topic. What we do know is that although few migration events can be attributed solely to climate change, it's definitely a threat multiplier, and it exacerbates existing socio-political and economic vulnerabilities. So in terms of some of the research gaps, and these are my last few slides, we have identified that, yes, there are some systematic reviews of the literature on this topic, but this needs to be extended further to really reveal how human health can be protected and promoted in the context of human mobility and climate crisis. There are underrepresented areas of the systematic reviews, which include less focus on trapped populations. There needs to be more focus on mental health impacts of climate-related migration and gendered health impacts of climate-related migration. In addition, there's little empirical research focusing on the health impacts, and also health systems resilience, including conceptual models of how to respond most effectively to include climate migration within health systems and climate migrants. Then there's the need to focus on specific climate change impacts such as sea level rise and rising temperatures. So in terms of the way forward, a few things that we have been working on. So our European Regional Hub did just publish a policy brief on climate change, migration, health, which coincided with COP26, highlighting a few areas for priority. And this was not just for European region, this was globally, including increasing collaboration between and within countries, diversifying our research methods to particularly include participatory research methods, and using modeling and forecasting to identify areas where populations might be most at risk. We also have other recommendations specifically for policymakers, UN, and the media. I won't go through them in too much detail, but there does need to be better funding for both research and implementation activities in this area, as well as preparation to mitigate for the health impacts of climate change for migrants. Key as well is ensuring universal health coverage, being inclusive of all populations and of all types of migration. So I think I'm going to end there. We have a lot more information on our website, and you can also connect with us at the email addresses shared. Thank you very much.
Thank you very much, Miriam. We will not be taking questions right now, but if you have some, please put them in the chat and we will address them in the Q&A session later on after the presentations. But for now, I would like to give the floor to Manuel Carballo. Manuel, you work at the International Center for Migration, Health and Development in Geneva, and you will be addressing a changing environment and the health security of people forced to move. Manuel?
Yes.
There you are.
Am I on? Good.
You're
Thank you. Thank you very much. And thank you for the invitation to be part of this discussion. I'll try to be very brief. I think Miriam has been so very comprehensive. So I think the first thing that I want to is accept that climate change is going to take many forms. Different parts of the world, different communities, different populations are likely to be affected by different types of climate change. I think the important thing for us to keep in mind from the perspective of human security and health security is that some of these climate changes are sufficiently slow onset that we have time to prepare for them, ideally. Some, on the other hand, are likely to be acute and will not provide countries with too much opportunity to prepare. We've all accepted that climate change is going to disrupt livestock production, agriculture, fishing, economic systems. These are all systems that are likely to affect health, healthcare needs, and the capacity of countries to respond to those needs. Now, in terms of which countries are going to be affected the most, or which regions are likely to be affected the most, I think it's important that we recognize that not all countries are going to be affected to the same extent, and some may indeed escape completely climate change. Tragically, the countries that are likely to be most affected are countries in which the health and socioeconomic condition is already compromised. And I've drawn a circle around that sort of latitude that includes most of sub-Saharan Africa, much of Southeast Asia. And I think as well as impacting on health systems, it's important that we recognize that political fragility in these countries may well increase and hence make it more impossible or difficult for people to cope or to adapt. And picking up on what Miriam has already said, more people are likely to be forced to move than ever before. Estimates range tremendously. Oxfam a few years ago talked about 250 million people by 2050. I think it's important that we recognize that people will probably travel longer distances than they have traditionally done. They will move through very new ecological zones that will have an impact in terms of public health. They will move through hostile zones. And when I say hostile, I don't necessarily mean health hostile, but socially hostile and politically hostile, with physical health threats, with psychosocial health threats. And I think we must keep in mind that for many migrants and refugees, whether they are climate change or not related, suffer tremendous psychosocial threats, including sexual violence and violence in general. Will there be elevated morbidity? Will there be elevated mortality? The reality is that we don't even know today, irrespective of whether it is climate change related movement or not, what the morbidity and mortality profile of people on the move is. Where will people go? Well, traditionally, of course, or in the last 100 or so years, the movement has been primarily from sub-Saharan Africa and other parts of the world to Europe and to North America. More particularly now, it's from Central and Southern America to North America, and increasingly from the whole of sub-Saharan Africa to parts of Europe. Now, as we look at what is likely to happen, we must keep in mind that of the 36 million people already crossing borders, forced to migrate, 85% of them are being hosted in middle-income countries, countries that, from many perspectives, are ill-prepared to deal with them. And for example, Turkey, Colombia, Uganda, and Pakistan together host a very large proportion of all people who have been forced to move in the last 10 to 15 years. Now, in terms of health security, we've all seen these pictures. We live with them every day, but it's important to keep in mind that from the perspective of those who are moving across borders, the opportunity to find health security is becoming increasingly limited. And in the bottom left-hand corner, a picture of something that is happening today on the Belarus-Polish border, the introduction of hypothermia as a major public health problem, one that we would probably not have thought of a few years ago. Now, of course, most people in the world forced to move or moving voluntarily will move within their own countries. And I think Miriam has referred to this. In 2021, 48 million people did so, and they moved to the closest safe areas. I've included this because I think we need to predict where people will move to as a result of climate change. And there is a high likelihood that they'll move again to the closest safe areas or perceived safe areas, which will be cities. Now, ironically, if we look at juxtapose the picture of likely climate change compromised countries in the bottom right-hand corner, and the countries where most people, large numbers of people are living in urban slums, we see how similar those two images are, which leads me to suspect that a large proportion of the people who will be forced to move and who will move within their own borders will end up in urban centers, but more particularly in urban slums. Now, we already know the magnitude of the urban slum population and its characteristics, but I think the main thing that we need to keep in mind in terms of health security is that 1 in 10 people today lack safe water, and that over almost 700 million are living in extreme poverty, a large proportion of those in urban slum areas. So when we think about health security in the context of a changing environment and forced migration, we need to keep in mind the pre-movement history, the fact that people are moving from situations that are already health and socioeconomic compromised areas, that the intra-movement experience is going to be not a pleasant one. We have evidence of this growing every day, and that the post-settlement experience, where people end up, is becoming increasingly incompatible with health security. And this we are seeing again every day in terms of the Belarus experience, the Polish border experience, which is only characteristic of something that is happening in many other parts of the world, but is not being publicized to the same extent. So in conclusion, we need to be much more alert and be able to predict how many people are likely to be forced to move, where they are likely to move to. We need to prepare for this in discussions with governments, offering not only policy options, but also examples of things that can possibly be done. And we must commit ourselves globally to delivering health security. And I think Miriam mentioned in one of her slides the issue of universal health coverage. Universal health coverage is something that we often forget when we're talking about migrants, whether they're climate change migrants or others. So a global challenge that I do not think is currently being taken up in a very effective or efficient way. Thank you.
Thank you very much, Manuel. And without further ado, I will now give the floor to Anita Fabos. Anita, you work at Clark University in Worcester in Massachusetts, and we work together in the same project called Misti, which looks at the impacts of migration on sustainability in cities. And your talk will address topics pertaining to this: mobility, social cohesion, and health outcomes in transformation to city sustainability. So please, the floor is yours for about 10 minutes. Thank you.
Thanks, Francois. And I also appreciate everyone's and especially Luciano's efforts in convening us today. Thanks very much for the opportunity to present some initial findings from our Misti research, which is part of a multi-sided project that looks at the relationship between sustainable development and migration in cities. We know that cities are continuously transformed through economic and social changes, including demographic shifts through migration. We also recognize that progress towards sustainability, especially during a time of converging climate change and the COVID pandemic, may be hampered by spatial and social inequality manifest in health and other outcomes. Our research, which I'll present today in Worcester, which is a small city in the state of Massachusetts in the eastern part of the United States, takes a health systems approach to examine how new migrant populations' experience of well-being and good health was affected by the pandemic and what this might help us understand for climate change adaptation. The COVID-19 pandemic demonstrates that health and well-being are integrally related to environmental, economic, and social sustainability, but also that its disruption has unequal effects across the globe and with relation to demographic categories such as gender, ethnic group, and place of origin. Health disparities themselves contribute to unsustainable societies and environments. In Worcester, the interplay of socioeconomic, environmental, transportation, and healthcare systems have also affected migrants and non-migrants differently, not only as they relate to demographic characteristics, but also due to the mobility and the mobile lifestyles of these populations. This presentation is an output of Project Misti, and we are overall assessing the impact of aggregate flows of people on sustainability, the individual life course dimensions of sustainability, and the governance of migration and sustainability across 6 different urban contexts. Our context in Worcester draws upon only part of our data collected so far, which was a qualitative interview process as part of understanding people's individual life course dimension.
Anita, I'm just interrupting for a minute because do you have slides to project? Because we don't see the slides.
Nope,
and there are some people asking if there are slides or if this is the way it should be.
It's just me, just
you.
face,
Perfect. Then
Francois.
please continue
so
and forgive my interruption.
Not at all. Sorry to everybody who would like to see something more lively on the screen. I apologize. But in any case, the city of Worcester, where our research is based, has a population of about 200,000, so it's on the small side, but at the same time is home to a significant population of migrants and refugees from around the United States and the world, including about 21% of the population who are foreign-born, originating largely from Latin American countries, with significant numbers of individuals from Ghana, Dominican Republic, Vietnam, Brazil, and Albania. Refugees make up a small but diverse percentage of the overall population. Massachusetts generally, and the city of Worcester more specifically, has comparably more inclusive migration policies than many other states in the US, and this may be reflected in the percentages of foreign-born residents of Worcester. After the state capital of Boston, Worcester also has the second largest formal refugee resettlement program in Massachusetts. International migrants and refugees, though, are not the only mobile populations in Worcester. Our study is including domestic migrants, and the city of Worcester largely is seeing this population in terms of students. So the city has 12 colleges and universities, which attract nearly 40,000 students to the city every year. And our research has included both these international and domestic migrant populations. Every specific migrant group faces, of course, their own set of challenges, especially when it comes to navigating the healthcare system in Worcester. These include, but are not limited to, language barriers, lack of health insurance, lack of culturally aware healthcare providers, high costs of healthcare, and distrust in healthcare providers and the system. During the coronavirus outbreak in the spring of 2020, the city of Worcester created the COVID-19 Health Equity Task Force. The main data suggest that newcomers experienced pandemic-induced mental health stresses that highlighted both socioeconomic disparities and mobility-related concerns. These data highlight differences in migrant experiences of well-being due to a disruption of urban systems and the importance of including migrants and other mobile people in social, economic, and environmental policies towards transformations. In July of that same year, the Health Equity Task Force was able to identify demographically specific information useful to approach the broader systemic issues of health within the city. Specifically, Hispanic migrants or Hispanic people from migrant backgrounds were the largest group to test positive for the virus at 31% of the testing population, far larger than their proportion in the population. The neighborhoods in Worcester with the highest number of positive cases were also found to be those with the highest population density, not surprising, but even in the case of those neighborhoods, the rate of Hispanic case positivity was as high as 53% as compared to white racial positivity remaining relatively low at 10%, even in high density neighborhoods. And we know that essential workers were more exposed to the virus as they had to continue to work in person, and for many to continue taking public transportation. Our research has shown essential workers as having a high percentage of migrants, as likely to be lower income, and as likely to be exposed to more health risks due to their essential worker roles. Furthermore, migrants tend to be clustered in neighborhoods where residential patterns are more dense and housing is of poorer quality. We also know from recent research that these neighborhoods have a high level of environmental pollution, such as brownfields from Worcester's industrial past and poor tree cover, leading to greater levels of urban heat in the summer months. Public transportation not only connects, but compounds these factors and adds to our understanding of how and why migrant communities in Worcester were disproportionately affected by the COVID-19 pandemic and the US, in the US context more generally. We're still in the middle of the COVID-19 pandemic, and it's probably too early to say with certainty how migrants will fare over the coming years as societies continue to cope with the ongoing climate crisis, health issues brought on by the pandemic, and in the United States particularly, the social unrest brought about by systemic racial and ethnic inequalities. But within this health systems context, several issues from our qualitative research stood out, with implications, we think, for how the health and well-being of migrants and refugees in Worcester may be affected by climate change. These issues are related to the particular experiences and contexts of mobility for migrants, highlighted by travel restrictions, lockdowns, and unequal access to green spaces, in addition to the socioeconomic limitations mentioned earlier that led to greater health risks and morbidity due to the virus. First, migrants reported high levels of stress and poor mental health as a result of the restrictions. While many of our respondents had concerns about not being able to visit family in other parts of the United States, migrants reported, especially foreign-born migrants, reported extremely high levels of stress due to travel restrictions, knowing that they were not able to reach their family members in different countries. This inability to move was compounded also by the worry about family members in different countries, in particular with those with fewer resources to combat the virus. One respondent from Cameroon was unable, due to travel restrictions, to attend the funeral of his mother, who died during the early days of the pandemic. His deep sorrow has been significantly worsened due to the ongoing conflict in his country, with family members caught between the fighting and the COVID lockdown. These stresses, we suggest, contribute to different health outcomes for migrants, especially in regards to mental health, compared to those based in the United States. Furthermore, disparities in access to green spaces was evident between our non-migrant and migrant respondents. While non-migrants appreciated the small scale of Worcester and the easy access to green spaces outside the city limits, access mainly required car transportation, something that many of our migrant respondents did not enjoy. The mental health and well-being that came from the ability to enjoy natural settings was less available to migrants. And we also know that the socioeconomic disparities that play out in Worcester in terms of how green the environments in wealthier neighborhoods are in comparison to those in more densely populated neighborhoods. Non-migrants reported a strong sense of well-being despite the COVID pandemic by being able to walk around their pleasant neighborhoods. On the other hand, our migrant respondents were limited in their mobility due to lower car ownership and access, compounded by Worcester's poor public transportation system. Even though the public bus system moved to a free system during the height of the pandemic, the bus routes did not provide regular or robust service to greener, less dense areas of the city, making it especially difficult for many from this population to access the natural world. We know that the interplay between urban and socioeconomic disparities, the built and natural environment, transportation, and access to healthcare have negative implications for social cohesion and, in turn, for healthy and sustainable societies. Our Project Misti research, including this work we are conducting in Worcester, includes the dimension of mobility, not only as it pertains to migrants as part of socio-demographic groups, but as it affects their capacity to remain connected to their supportive social networks, access health services, and be included as members of local communities. Cities that include an understanding of the health aspects of mobility in their planning towards health and sustainability may be better off in addressing climate change adaptation. Thank you so much.
Thank you very much. Thank you, Anita. I see that there are some questions in the chat, and perhaps you can see them, and some of them, I guess, can be answered in a written format. Now, I would like to give the floor to Robert McLeman from Wilfrid Laurier University in Canada, and Robert, you're also the coordinating lead author for the chapter on human health in the upcoming report from the second working group of the IPCC, and you will address the links between climate risks, migration, and health outcomes. So thank you for being with us, Robert.
Merci, Francois. Hello, everybody, and good morning from a snowy southern Ontario in Canada. And good afternoon to those of you in Europe, and good evening to those of you in Asia. I'm afraid that, like the previous speaker, you're going to be stuck looking at my face for the next few minutes. I didn't prepare any slides, but that was by design. I realized, being in the middle of the program, a lot of the people who spoke before me would take all the good stuff and leave me with, a few little bits and pieces to add in. And so I've been taking notes while they were speaking. And what I hope to do now is just sort of fill in some things that I was thinking about over the previous three speakers, who started sort of from a broad scale and then moved to a regional and then a very local scale in terms of their progression of analysis of how climate change, migration, and migrant health interact with one another. So what I'm going to do then is just sort of break down my comments into sort of three sections. One is on the linkages between climate change and migration, on the linkages between climate change and health, and then trying to pull them together, the interconnections between the three. And so, yes, I will be drawing on some of my experience that has come from working on the IPCC reporting, where we assessed literally thousands of publications that have been released since 2015 on the links between climate change and health, climate change and migration. And then, as one of the previous speakers noted, a small number of publications that have come out in recent years about that pull together the three ideas. Okay, so moving straight ahead then, in terms of the links between climate risks and migration, we heard talk earlier about the different types of climate risks that are out there. And generally, scientists categorize them into slow progressing or slow onset events versus sudden onset events. So the slow emerging ones you can think of, for example, the rise in average temperatures around the world, which in coming decades are going to render certain cities and certain countries extremely hot in the summertime, especially in the daytime. And so there are health risks associated with exposure to high heat, especially in communities where people do not have full access to air conditioning or other ways of keeping cool. Sea level rise is another one that is sort of a slow emerging one, and it's already creating migration and displacement risks in certain parts of the world. Low-lying coastal communities, often indigenous communities here in North America. In Fiji, for example, there's already a move afoot to start relocating small coastal villages away from rising sea levels. So those are the slow emerging ones. The more sudden ones are ones that we're familiar with: extreme storm events, floods, droughts that emerge slightly more slowly than those previous two events, and also new sort of risks that are on the horizon, like wildfires and so on. And I know that we have representatives from the Internal Displacement Monitoring Center on the panel, so I won't speak a lot except to say that IDMC has been doing a lot of great work assembling statistics so that we have a good idea of the scale of these different events in terms of their impacts on displacement. So we know, for example, that the floods and the storms are the big ones in terms of absolute numbers of people being displaced. And we know where these big displacement events are happening: Southeast Asia. The United States actually has a lot of displacement events. In terms of absolute numbers, those regions are the greatest, but as one of the previous speakers mentioned, small island states and rural coastal communities are often more highly exposed to the risks of displacement. And displacement is really just one subset of the larger scale of the impacts of climate change on migration. And I heard talk earlier about people adapting and voluntarily migrating. I also I picked up on the observations that migration in response to climate change is often multi-causal. I mean, obviously, if a hurricane blows into your community and knocks down all the homes and you're unable to rebuild them successfully, it's pretty obvious the cause and effect. But in many cases, the people who are on the move, climate factors interact with economic, social, cultural, and other factors to create sort of a soup of causality that leads people to decide to migrate. And so we often talk about multi-causality. We also often talk about multi-directionality, which is that the same climate event or the same weather event might trigger different types of migration among different social groups. If we think about Hurricane Katrina, for example, over a decade ago, that flooded New Orleans, that city saw people move away indefinitely. It saw people move away temporarily and return. And it saw an influx of migrants, often out of status migrants, who were looking for work in the construction center. So there a sector. So there's a lot of churn, if you will, a lot of different migration flows out of this one event. As one of the previous speakers noted, most climate-related migration is internal within countries, and I note the very important factor that a lot of it is directed from rural areas into urban areas as well, creating additional pressure on resources in urban centers. When it is international, it tends to be between contiguous states. We see the headline stories about migrants in boats crossing the Mediterranean or the English Channel. We see what's happening on the Polish border, but really that's just a small sampling of the much larger scale of people that are on the move in many parts of the world. Now, we know with respect to climate change, especially given the current emissions trajectories that we were on for greenhouse gas emissions, these high emission scenarios will almost certainly lead to increased frequency and severity of these extreme weather events in many parts of the world and accelerate the rate of warming and sea level rise. We also see a lot of population growth in areas that are already highly exposed to these climate risks. So we've got this sort of bad dynamic, if you will, with increasing climate risks and increasing numbers of people living in highly exposed areas. So the conclusion is that in coming decades, we can almost certainly expect more and more people on the move for climate-related reasons. Now, to quickly think about some of those links between climate risks and health risks, in the IPCC process, we talked a lot about climate-sensitive health risks and climate-sensitive health outcomes. And these can be communicable diseases like waterborne diseases, foodborne diseases, which are often the highest source of premature loss of life in low-income countries around the world. Climate-sensitive vector-borne diseases like malaria, tick-borne diseases, and so on. But there are also climate-sensitive non-communicable diseases like the effect of extreme heat on respiratory health, cardiovascular disease. Of course, we have to think about the impacts of climate change on nutrition and malnutrition or undernutrition, especially in low-income countries, injuries associated with extreme events, and something that is just sort of coming out in the literature now is the impacts of climate change on mental health and well-being, something that has been overlooked for a long time, and I'm seeing a lot of research emerging on that. And the pathways for all of these things between climate change and health outcomes can be direct or indirect. Obviously, the injuries is an obvious pathway for, after extreme events for a pathway in terms of health outcomes. But there's also after an extreme event, the anxiety, the loss of livelihood, the stress, and in some cases, the PTSD that may emerge among certain groups of people in the wake of this. So science seems to be really moving into a sort of a broader well-being approach and recognizing that the specific nature of risks of climate change on health are very specific to particular regions and groups, and also reflect in many cases the pre-existing health systems in the exposed regions. Let me now just sort of wrap up by giving a few thoughts on the links between climate change and migration and migrants' health. Again, as noted earlier by Miriam, this is not especially well studied, but there's sort of three things I'd like to highlight within this field. One is that the circumstances of migration are highly influential on the health outcomes. So are we talking about people who are voluntarily migrating or involuntarily migrating or somewhere in between in that continuum? Are they within their country of origin or outside their country of origin? And if they're outside of their country of origin, do they have legal status? Do they have legal access to healthcare systems and facilities? Because obviously that's a huge determinant in their future health trajectories. And if they're in their home country, are they mobile people within their home country, or are they immobile? Are they trapped in particular locations? And when we talk about immobile people, as mentioned earlier, we can be talking about people who might want to leave the location where they are, but lack the ability to do so. Or they may be people who, as an outsider, you would say, why don't they leave this location? But they're extremely closely tied to it for cultural, economic, or social reasons, for example. Second consideration is the demographic characteristics of the migrant population we're talking about. Are they disproportionately older or younger? Are they disproportionately male or female, or is it a heterogeneous mix of people? And what is the physical ability of the people? Because obviously these things determine the health needs and risks of the group. And then the third thing are what you could call micro scale factors. So do the migrants themselves have pre-existing health conditions? Are they have they moved to a place where they share a similar culture, or is it a very different culture? Is their economic and educational attainment and language skills the same or different from the receiving community? What is their access to housing, food, basic needs, and so on? These are all factors that determine the outcome. And then even the circumstances of the migrant journey itself. Have they arrived in a relatively safe and orderly fashion? Or are they like the folks right now who are in Panama, who are moving their way on foot from Colombia through Panama northward into Mexico and eventually the United States. Obviously, different health risks associated with the migration journey itself. So to wrap up then, what I would like to focus on when I talk to policymakers is that migrant health outcomes, so if the risk continuum, if you will, is often determined or heavily influenced by their status, their legal status within the country of origin, within the migrant process itself or migration process itself, and within the community that receives them. So migrants whose movement is voluntarily and have status in the destination area, have access to labor markets and health facilities and so on, their health risks or needs are going to be relatively similar to those of the recipient population. Involuntary migrants or trapped populations of people who lack legal status, who are vulnerable for social economic reasons, they're going to have very different and often more pronounced health needs, health risks as compared with the population that receives them. And then the involuntarily immobile people, the trapped populations within their home countries, again, they're going to have more pronounced and very different health risks and needs than other members of their same home community. So I think I'll leave it at that and turn it back to Francois and the other speakers. Thanks for your time.
Thank you very much, Robert. Very inspiring. I will now turn to a presentation that will be looking at empirical results, especially from Ethiopia and Somalia. And those will be presented by Luisa Yasukawa from the IDMC, the Internal Displacement Monitoring Center in Geneva. And in these two cases, in Ethiopia and Somalia, you will be looking, Luisa, at the health impacts of internal displacement in the context of climate change.
Francois, and can everyone see my screen?
Absolutely, at least I can.
Okay, great. Thank you very much. So my name is Luisa Yasukawa, and I'm a research associate at the Internal Displacement Monitoring Center based in Geneva. So today I'm going to be focusing on internally displaced people who, as Manuel noted, make up the majority of the world's forcibly displaced population. So about 55 million people were estimated to be living in internal displacement in their own countries at the end of 2020 as a result of conflict, violence, and disasters. And as Robert explained, the impacts of climate change are increasing the frequency and intensity of slow and sudden onset hazards, which are forcing more people to flee their homes. So today I will discuss some of the health impacts of displacement, which, as Francois said, will be drawing from two case studies we conducted in Ethiopia and Somalia. But before doing so, I thought I'd just give a brief overview of who we are as an organization. So IDMC sits within the Norwegian Refugee Council, and we provide data, analysis, and expertise on internal displacement linked with conflict, violence, and disasters. And the aim of our work is to inform policy and operational decisions to reduce the risk of future displacement and improve the lives of IDPs. So here you can see the grid is our global report on internal displacement, and it's our flagship publication that includes all our estimates for the year of the number of people displaced in each country and patterns of their displacement. And this year we had a special focus on internal displacement in a changing climate. I've pulled out just some other areas of research that have touched upon health that we've published. Here you can see we published a joint fact sheet with UNHCR and the International Disability Alliance, looking at the intersection of disability, displacement, and climate change. So on to the case studies. At the beginning of 2021, we conducted two case studies, the first of which examined the socioeconomic impacts of displacement linked with drought in Liamo Gorewareda, Ethiopia. And the second case study was focusing on the impacts of displacement linked with recurring floods in the town of Beledweyne, Somalia. So for both studies, we conducted household surveys of about 150 IDPs and 150 non-displaced persons. And for ease of reference, I'm going to call them hosts throughout this presentation. And we used an original survey tool, which aims to measure the impacts of displacement on 5 dimensions of people's lives, being their livelihoods, health, education, housing, and security. And the results of our study were disaggregated by sex, age, and disability status, as well as main language spoken in the home. And we also conducted key informant interviews to complement the findings. So in Ethiopia, the majority, all surveyed IDPs were pastoralists who left their home area because of drought and their inability to keep their cattle. And they arrived in Liamo in February 2018 and April 2020, so between those two dates. And Gode Wareda is in the Somali region of Ethiopia, and the government of the Somali region has also recognized that climate change is one of the main drivers of displacement. And indeed, in 2020, some 331,000 people were displaced by drought in Ethiopia. So most survey IDPs were renting accommodation in Liamo, and 9% of the surveyed hosts were currently sharing their home with IDPs at the time of being interviewed. So part of the study was looking at the physical health of IDPs and hosts, and we asked them to compare their physical health before displacement and after. So here you can see where that red arrow is, that 44% of IDPs said their physical health had worsened since their displacement. And they cited poor access to food due to loss of cattle, shortages of clean water, overcrowding, disease such as malaria and diarrhea. And we also saw that there were health impacts for the host community as well. So 22% of hosts said that physical health had also worsened, and this was primarily due to overcrowding in health facilities. There were, however, some recorded positive impacts. The 20% of hosts said their physical health had actually improved, and this appeared to be linked to the fact that there had been better investments in the health system after the arrival of IDPs in the area. So here you can see one quote I've pulled out from a respondent who said, after the IDPs arrived, the health professionals and facilities improved. Healthcare facilities are being constructed and the conditions are better than ever before. So we also asked about access to health and how that's been impacted by displacement. And over half of the IDPs said their access to health had improved since moving from their rural areas to Liamo. Public and private healthcare clinics are available, and some NGOs run mobile health clinics as well. When we looked at the differences in the cost of seeing a healthcare professional, the findings were quite striking. So IDPs reported that the average cost of seeing a health professional in the host community was $35, compared with $5 for hosts. So we dug a little deeper and we found out that for IDPs, although the majority said that their access to healthcare had improved, they still tended to live in more remote areas of the host community, so still had to travel significant distances to reach health facilities and even sometimes stay overnight. So the cost of $35 on average also included the transportation and accommodation that they incurred as well, highlighting some of the hidden costs that may have otherwise been overlooked. Moving on to Somalia. So the focus of the case study in Somalia was on recurring flooding. So the town of Beledweyne is traversed by the Shabelle River, and heavy rains caused the river to overflow, flooding much of the city, which, as you can see in this picture to the left. So that people who are displaced from the flooding tend to find refuge in higher parts of the city or in the surrounding villages. So floods have become more and more severe, and this has been linked to climate change, urbanization, and poor land management practices. But they've become so frequent that people now prepare in advance for them. So the surveyed IDPs had been displaced in the last 12 months, most for between 2 weeks and 3 months, and all had been able to return to their homes afterwards. All surveyed hosts had shared their homes with IDPs at some point as well. So in terms of the health challenges, several organizations do provide emergency health support to IDPs through mobile clinics and even via boats, but there were still significant challenges that were identified. So here, one local health professional noted, when floods occur and people are displaced, the main health issue is acute diarrhea, followed by measles, which is caused by overcrowding and congestion. They go on to note that common colds are also an issue, and that there is a lot of malaria because of high temperatures and the increase in water catchment areas. So in addition to that information, as I mentioned, we also disaggregated the results by disability status. So within the sample in Somalia, 4% of surveyed IDPs in Beledweyne were identified as having a disability by the Washington Group short set. And 25% of surveyed displaced households included at least one member living with a disability. And here you can see in the graph, majority of the disabilities were linked to vision and mobility. And in both case studies in Ethiopia and Somalia, the findings highlighted how people with disabilities can be disproportionately impacted by displacement in a changing climate. So here you can see that one of the main challenges is even escaping the effects of a disaster, which I know Robert touched on immobility as an issue. So it's interesting to note one of the representatives of people with disabilities mentioned that floods affect people with disabilities the most in this town. Almost 30% have to crawl to reach their destination. There are no vehicles to transport them and no wheelchairs that can withstand the water. And so in addition to challenges moving to a safer area, we also found that people with disabilities face significant barriers accessing specialized healthcare in displacement, as well as livelihoods, which can have further repercussions on their health and their ability to find durable solutions to their displacement. So in conclusion, I've just touched on a few of the key findings, but I can share the case studies with the full results. But the findings highlight that the health impacts of displacement in a changing climate are diverse, and they affect not only IDPs, but also host communities. So there's definitely a need for better data, as well as more inclusive support to mitigate these health risks and ensure that particularly vulnerable groups, such as persons with disabilities, are not left behind. Thank you very much.
Thank you very much, Luisa. And to conclude this panel, we know of Alice Baya. Alice works at the Division on Migration, Environment and Climate Change of the International Organization for Migration, IOM, and she will address the impact of the COVID-19 pandemic on migration and climate change. I should say that the IOM has been running a blog series on this topic, and obviously this is an event that really shed into the limelight the issues pertaining to migrants' health in relation also to climate change. So Alice, the floor is yours. And yes, we can see your slides, yes, but we cannot hear you. Yes, we can hear you.
So yeah, you confirm, Francois, you see my slide. You see my slides?
Yes, absolutely.
Okay, super. Thank you. So thank you, Francois, and thank you, Luciano, for the invitation to join this webinar. And as Robert said earlier, a lot has already been said by previous speakers, especially when you are the last one to take the floor. So I will try on my side to contribute to this discussion by focusing during the next 10 minutes on some of the lessons learned from the COVID-19 pandemic, as I believe it's also insightful to better understand how climate change, migration, and health issues are interconnected challenges. And because I think we all know that the pandemic has had various implications on migrants, refugees, and displaced persons, and it often increased their vulnerability, either because there is a specific challenges faced by people displaced by disaster to respect distancing and hygiene measures, or seasonal workers unable or forced to go home, or communities relying on migration as an adaptation strategy, but who have stopped receiving remittances during the pandemic. But at the same time, COVID-19 has been also pushing many actors to reconsider how to handle disaster evacuation and displacement. And thus, I think the pandemic can act as a catalyst for change if we learn the necessary lessons in terms of possible improvement and additional challenges. So I'd like to present actually today some of the findings from the IOM blog series on the COVID-19 pandemic, migration and the environment. So this blog series is actually an initiative started by IOM last year, which gathered more than 20 contributions from both practitioners and researchers from different backgrounds and different regions of the world. And it provides, I think, a good snapshot of the diversity and complexity of the implication of the pandemic on human mobility in the context of climate change and disasters. And just to mention that IOM also developed an infographic that you can see on the slide with main messages regarding the links between climate change, migration, and the COVID-19 pandemic. And I'll be happy to share this infographic after my presentation. I will look also at two main contexts in particular, and I will attempt to draw lessons from each of them. So the first is to look at the impact of the pandemic on people displaced by disasters. And the second context is to look more at the impacts on seasonal migration. So to start with the first, so some lessons learned from responding to disaster displacement in times of COVID-19. We can already say that last year, so in 2020, and according to IDMC data, about 30 million internal displacements because of weather-related disasters have been recorded, mainly in East Asia and the Pacific, as well as in South Asia. And a vast majority of people evacuated and displaced by disaster last year had to move in the wider context of the pandemic, and thus been exposed to additional risk of contracting or spreading the virus. So it created huge challenges for authorities and aid agencies to deal with the necessity to move people out of harm's way, while at the same time controlling the spread of the virus by limiting population's movement. But the pandemic has forced disaster risk reduction and humanitarian actors to grapple with the long-standing issue of overcrowded and sanitary displacement camps. So it has led to the introduction of various measures to ensure social distancing, stricter sanitation, and infection control in order to prevent evacuation centers and displacement camps from turning into virus hotspots. So to give a few examples, the government of Bangladesh, for instance, has used mosques and schools as additional evacuation center to prevent overcrowding during Cyclone Amphan in May 2020. In Costa Rica, if we look at the other side of the world, after some heavy rains caused severe floodings and landslides in June last year, the National Emergency Commission set up special shelters for the elderly and people considered at high risk of contracting the virus, as well as separate shelters also for confirmed cases of COVID-19. And in some other cases, a greater cooperation with the private sectors by expanding in particular the use of hotel or shopping malls as emergency shelters have also been observed. It has been the case in the Netherlands, for instance, where about 4,000 residents of a village had to be evacuated in hostel due to wildfires, but also in the US, where the American Red Cross has also prioritized emergency hotel instead of shelters to relocate people affected by tornadoes. So in my view, those examples demonstrate that the COVID-19 pandemic can also be a catalyst for change to better address on the long term disaster evacuation and displacement, especially by putting in place measures reducing overcrowding in camps, and thus contributing to contain not only the spread of COVID-19, but also of other infectious diseases and other health risks. At the same time, and to give another perspective, lockdown measures and movement restriction has also hindered outside aid support to reach out to disaster-affected communities. And those restrictions led to delays, for instance, in response and recovery activities, and it has increased the risk of prolonged displacements in some cases for the evacuees. And we can mention here the case of Vanuatu after tropical cyclone Harold hit the country in April 2020. And the government of Vanuatu had to seek actually a balance between delivering humanitarian aid and protecting its citizens from COVID-19. And so the government has required for international humanitarian workers a quarantine of 14 to 28 days. And the government has also put in place very strict protocols around incoming cargo to provide aid supplies. And those kind of protocols have created significant delays in the delivery of such life-saving supplies for affected persons. So as a result, the food security has increased in Vanuatu, and many people have faced prolonged displacement after the cyclone. So one of the lessons that we can learn from this example of Vanuatu is also the centrality of local humanitarian responders and the importance of building the local capacities in order to most effectively assist vulnerable communities in the face of a disasters. And the situation in Vanuatu, but also of other Pacific islands that have been affected by Cyclone Harold, also made very clear that climate change adaptation and disaster risk reduction remain essential and also urgent imperatives for countries vulnerable to sudden onset disasters, and that these efforts, DRR and adaptation effort, must continue in the midst of the COVID-19 pandemic response and recovery. Another aspect that we can mention is also that the simultaneous occurrence of disasters and the pandemic in some contexts has enhanced the vulnerability of people already displaced by conflict and violence. And it is particularly well shown in one of the contributions of the blog series written by Adama Dembele, Pierre Other, and their colleagues, where they analyze the contribution, in their contribution, the component and combined effect of COVID-19, floods, and conflict on IDPs in the region of Kongusi in Burkina Faso. And they show that they demonstrate that closure of food markets, quarantine of the Kongusi locality, mobility restriction, curfew, all of these measures have impacted the livelihoods of IDPs and trapped them between terrorism, climate change, and COVID-19. And the same authors conducted a survey in May 2020 among IDPs in Kongusi, and this survey revealed that the quarantine of the locality and the lockdown measures have deprived 85% of the respondents of their sources of income, which were relying mostly on the informal sector. The study also showed a significant decrease of the international aid to IDPs in Kongusi and a focus on sanitary activities in the camps to the detriment of other livelihoods activities. And this situation in the IDP camps in Kongusi was aggravated by the early occurrence of floods in April 2020, which literally flooded the camps of IDPs. And authorities and humanitarian actors who were all focused on the health emergency have been unable to relocate on time the IDPs, and which led to an increase of their vulnerability and deteriorating their living conditions. So as a result, and as shown by the survey, income generating activities of IDPs have been severely impacted by those measures. It has increased their food insecurity and their needs for financial and housing support, and also reduced their ability to cope with additional stress, such as the floods. But I'd like to now turn quickly to the second context, because sudden disaster displacement is not the only way climate change, human mobility, and COVID-19 can collide. And many people, especially across the developing world, also migrate to cities to find work as a means of coping with slow onset processes, either it is drought, sea level rise, erosion, or salinization, for instance. which particularly affect the agricultural sector on which millions of people rely. And when people migrate for work to cities or abroad, they very often send money home to their families, what we call the remittances. And in drought-prone area, for instance, the money sent home gives the family a source of non-agricultural income, and the money can be invested in climate adaptation measures, which allow families to accommodate changes in rainfall and temperature patterns, and as well as crop productivity. But during COVID-19, most of the urban economies have been paralyzed, and many people found themselves trapped in drought-prone area because they were unable to move to cities. But at the same time, as cities go into lockdown and people were laid off, remittances sent to rural families have dried up too, leaving them less able to cope with the drought or other climate change impacts. And it has removed also a vital economic safety net in those rural areas. And other persons have been also forced to leave the cities to which they have moved and return to environmentally vulnerable rural areas. And one example that we can mention here, and I think everyone has seen it in the news, it's the case of India with the impact of the lockdown on internal and Nepali migrants workers. And those impacts have been dramatic for those persons because millions of them had to return to rural areas, which they initially left partly because of environmental degradation, and they had to undertake a long and dangerous journey, most often without sufficient food and water, and also with the fear of being arrested for violating the lockdown. And so this dramatic situation in India has revealed as well the lack of social protection for migrant workers, the dire conditions in which they live in, and the stigmatization they are also subject to. And a remote, just to give a last example, but a remote qualitative study conducted in Somalia by the universities of Nairobi and Cambridge, together with the Africa Voice Foundation, has also shown that the loss of work and income in Somalia has caused additional displacement, with people forced to join an IDP camp in Somalia because they have lost their livelihoods and have no other options. So what can we learn from these different situations? And I will just conclude by sharing a few recommendations for further actions and reflection on these complex and interconnected challenges. But as we have seen, the COVID-19 pandemic has put an additional layer of vulnerability on migrants and displaced persons who were already affected by the adverse impact of climate change and disasters. But there is also a lot that we can learn, as I've said at the beginning, from the pandemic to better respond to disaster displacement and environmental migration in future. So first, because urbanization, and it has been said previously, but urbanization is driven by environmental degradation and depleting livelihood in rural areas, at least partly driven, it's also very likely that those migration from rural to urban areas will continue to increase. So we need to prepare our cities, we need to make them safe, including for migrants who often settle in overcrowded informal areas in urban context. And COVID-19 has shown how migrants were too often excluded from urban social and health services. In this regard, the Singapore example is speaking as well, as the city has experienced a series of coronavirus outbreaks, starting in dormitories where thousands of migrant workers live. And so it's urgent to implement long-term solutions for internal migrants through the development of migrants inclusive urban policies, but also through their inclusion in national health coverage plans. A second recommendation or second reflection is that climate change does not stop during COVID-19, as we know. and disasters have continued to hit different regions of the world since last year. So climate action is required, and it requires long-term and sustained mitigation and adaptation efforts. And those efforts should not be halted or hampered by socioeconomic recovery efforts. It should be part of it in order to build back better. A third point is that we need also to facilitate safe and regular migration pathways as encouraged in different global policy frameworks, and in particular in the Global Compact on Migration, in order to make sure that people move in safety and dignity, including in times of crisis, and that those persons do not remain trapped in dangerous and degraded environment. A fourth point is that we need to ensure that migration and health considerations are addressed in climate discussion and vice versa. And we also need to promote policy currents across various policy frameworks to ensure that the impacts of climate change on migration and migration health are well addressed. A fifth point is that we need more data also, of course, to better understand these interconnected challenges of migration, health, and climate change. And it has been said already by previous speakers with research recommendation. So I will just go to my sixth and last point, which is that we also need to collect and identify good practices. We need to share information, experiences, and lessons in order to better address these challenges and ensure that no one is left behind when responding to a crisis, either it's a health crisis or a climate crisis, and especially even more when it's a combination of the two. I will stop here. I would just like to mention, and you can access to the recording of these events on the website, and I will give the link after. But IOM has joined also the World Health Organization and the Lancet Migration during COP26 to also organize a few side events to promote and to trigger reflection and action on this nexus of migration, health, and climate change, and to put this topic on the climate agenda and in the climate discussion. So we had two side events at COP26, one in the health pavilion and one in the French pavilion. And as I said, you can access the recording after. And the three organizations, so both from all IOM, WHO, and the Lancet, will continue their efforts in future to work on this triple nexus. And if you want to have or look at additional resources on this topic, I invite you to go on both the Environmental Migration Portal of IOM as well as the Migration Health Research Portal of IOM. On both these websites, you will find additional resources that are relevant for the discussion today. And thank you for your attention, and sorry, I think I've been too long.
Not to worry, Alice. Thanks a lot. That was very comprehensive. And the good news is that we still have about 35 minutes for questions and answers. I know that we have more than 50 participants online. So let me see if we have questions online. And if we don't have questions immediately, maybe I will take some questions from the chat and ask them to participants. Do we have questions online first? If there are no questions online, and maybe will be on their way in the future, a question about how it is possible to identify and prioritize the areas to improve maternal and newborn services. In other words, the question was, given that climate change is affecting the health of migrants and refugees, how can we identify and prioritize the areas where improvement of maternal and newborn services is most needed? Do some of the panelists, and the question is not addressed to a panelist in particular, do some of the panelists have an idea about that? I don't see anyone volunteering. And perhaps we can open up the question and try to say a few words about the need for improvement of maternal and newborn services, especially in places where refugees and migrants are located, without necessarily identifying a specific place. But perhaps it would be useful to know where what are the needs to improve these maternal and newborn services.
Francois, I think
Yes.
I'll help, not because I'm an expert on maternal health, but to help the conversation get going and refer back to our work that we did in the IPCC assessment that would be forthcoming in the springtime. And this was a group that we focused on, and in terms of vulnerability in particular, you know, pregnant women, women with young children, both in terms of their exposure to climate-sensitive health risks, and also the reality that they often are underserved, especially in low-income and middle-income countries, in terms of having their health needs met. So, for example, you know, when you talk about extreme heat events, you know, pregnant women would definitely fall within, for example, a more vulnerable, more highly exposed group in terms of adverse health impacts. Again, thinking about migrants and displaced people in particular, often living in highly exposed regions with limited basic needs, poor quality housing, poor access to safe drinking water, poor nutrition, and so on. So we see it as sort of a compounding factor, the climate risks that are affecting a population of people who are often extremely vulnerable in the first place, irrespective of climate change. And so this is definitely an area where there needs to be greater focus in general, even forgetting about climate change as the risk factor. This is obviously an area where there needs to be more work. So hopefully that gets the conversation going for you.
Thank you, Robert. Other panelists have some other comments, maybe? Yes, Anita, I see you.
Well, I maybe just following on from how Robert, you know, phrased or you know, characterized the health issues for you know, particularly vulnerable populations like, you know, climate affected migrants. I'm also thinking just from our work in Worcester about the systemic aspects of socioeconomic inequalities that also, you know, that help cement some of these poor health outcomes for maternal and child welfare and well-being. And, you know, I think regardless of where a city, in my case, or other planning process is, starting to tackle or continuing to tackle more fully those systemic inequalities regarding, you know, health, and in our case, you know, racial inequities, is really, really a priority. We can see how this is going in Worcester. And I think one just area from my research with refugees and migrants myself is involving more people from those communities in the research design, in identifying the problems and trying to figure out what the contextual or population specific concerns and problems are. So that's something that I think one of our colleagues was referring to, just more ethical research practices that really involve affected populations in thinking about what would be good practices for that group.
Maybe, yes, Louisa.
Oh, I just wanted to add that, in fact, our case study in Somalia touched on this issue, and a representative from the displaced women's community said that there were significant barriers for pregnant women in accessing healthcare, just as they were about to give birth. So I think, as the panelists have said, it sort of speaks to more broadly the importance of disaggregated data and trying to go behind the numbers a bit to see how different groups are disproportionately impacted, and particularly, as said, barriers that women face in accessing livelihoods during displacement then in turn can affect their health incomes and the security risks that they face. So yeah, just to reiterate the importance of looking at gender trends between the data.
Thank you. Maybe to continue the conversation, a question from myself also about the needs in rural areas and in urban areas. Obviously, one of the effects of climate change is to drive people from rural areas to urban areas. And this is typically where the health services are concentrated. But perhaps we could say a few words about the need for health services also in rural areas, and how one of the reasons possibly also driving migration to cities is the presence of health services in cities. Manuel.
Yeah, thank you, Francois. I'd like to come back first of all to the last issue, the one of maternal and child health. I think we need to keep in mind that one of the barriers to better maternal and child health is the fact that MCH has not been given high priority in many, many countries, irrespective of their social economic situation. Secondly, there are cultural issues that need to be taken into account. And thirdly, that we have often assumed that unless we have highly specialized healthcare personnel available, that maternal and child health activities will be restricted. We need to, I think, recognize that midwives can play a very important role, and that there is an opportunity in most communities to train existing traditional midwives, give them more training and allow them to perform the role that is often in high-income countries given over to obstetricians and gynecologists. On your last question about healthcare in cities, I am not sure that we can say that healthcare services improve in cities. During my presentation, I raised the issue of slum areas, and there are over 1 billion people today living in urban slums. Very often, access to environmental sanitation, to clean water, and to healthcare services in urban slums is not particularly better than it is in rural areas. So I think that given that we are moving into an era of urbanization, of urban communities, I think it behoves us to call for far more attention to be given to the development of primary healthcare services in urban slums, always under the umbrella of universal healthcare coverage. Far more needs to be done in urban slums. Thanks.
Thank you, Manuel. Other panelists maybe would like to contribute to this discussion also on the balance between rural and urban areas. There doesn't seem to be many volunteers.
Francois, I'll happily jump in. Sure, thank you. So yeah, I mean, we see this on every continent. It just manifests itself in different ways in terms of the impacts of climate change and drought and migration on rural populations. I'm in North America. Here in the 1930s, many of the challenges that we talk about today in low-income countries, we experience here in North America in terms of drought, displacement of people on the North American Great Plains, people living in informal housing, separated families, women and children being especially vulnerable to the impacts of the combined effects of economic recession and the hardships created by the drought, elderly people being faced by a wide range of health challenges. It's very well documented. We just have a sort of a collective amnesia here in high-income countries that these things happen. But of course, the reality is in the coming decades, we have two things going on, is that we have extremely large population growth rates in many parts of rural areas of low-income countries in the global south. There's a very young population in many of these regions, and people who want not just access to healthcare, but access to economic opportunity as well. And so there's a lot of social and economic drivers that layer on to the climate stimuli that are pushing people from rural areas to urban areas. And so it will create challenges, definitely, pressure points on cities that already in many cases in low-income countries are struggling to cope with the influx of rural migrants and the local population growth as well. Finding jobs, housing, basic needs for all these folks. So yes, and health gets layered into that, because at the end of the day, when we think about the adverse impacts of climate change and why we should care, a lot of it boils down to human health and well-being. And so, obviously in low-income countries, this rural-urban dynamic is going to happen anyhow in the absence of climate change. But I feel like we're just going to see an acceleration of this process and a magnification of it, with all kinds of potential adverse incomes, including on health outcomes.
Thanks, Robert. I don't see any other interventions on questions. All right, so on this note, I would like to thank all the panelists for their insights. That was certainly a very insightful panel. Thank you very much, Luciano, for the organization. And no doubt that this is a topic that will keep on emerging, and that even though both climate change and health and migration and health are topics that are usually addressed together with one another, there is no doubt that the three together will continue to be increasingly addressed as a kind of, a nexus between three elements. So thanks a lot to everyone. Have a good day if you're in North America, a good afternoon if you're in Europe, and a good evening if you're in Asia or elsewhere. Thank you so much, and have a good day until soon. Thank you.
Thank you. Bye, Francois.
Thank
See
you.
everyone.
See you next time. Thanks a lot.